This
फेवरेट
conference
क्वेश्चन है
will
ना,
now be recorded.
हिस्ट्रेक्टमी तो वो हमेशा पूछते हैं, किसी को वैजिनल पूछते हैं, किसी को गायनिक पूछ लेते हैं, ठीक है। तो वो आपने घबराना बिल्कुल नहीं है। दे विल आस्क यू द स्टेप्स, जैसे बच्चों के सुनते हैं ना, ऐसे दे लाइक टू लिसन फ्रॉम यू दैट व्हाट आर द स्टेप्स लाइक दैट, ओके। So this is your first case. Just look at this one, then we are going to have a discussion. Your time starts now, okay? Now you should be doing only the timed practice.
Okay. Okay.
Once you finish reading, then tell me, okay? So we'll go over the questions one by one.
Okay, we can start.
Okay. So what can you tell me about this patient?
So our patient, Mrs. Alpha, she is planned for myomectomy, and she has a history of um, she has a history of infertility for 8 years, and previous history of two early miscarriages.
Okay. So what issues would you wish to check with her on your pre-operative ward round?
In preoperative ward round, I would like to confirm that patient has given informed written consent, and all the risk and benefit associated with procedure is discussed, and patient information leaflet is given, and a consultant is informed regarding the procedure, and in preoperative period her pregnancy test is done and pregnancy is excluded, and anesthetic assessment is done, and full blood count for hemoglobin is done, and group M is available.
Okay.
We took the history, detailed history regarding her medical history, any medical illness, and whether she's on any medicines or whether she's taking any hormonal contraceptive pills which needs to be stopped before procedure, and her any reservation for blood transfusion she has. And so these issues I need to be discussed before in the pre-operative ward round, and also I need to know her body mass index, and
Mhm.
it is important, and make sure that enhanced recovery program is followed, and
Okay.
so in pre-operative ward round I make sure these.
Okay. So will you like to do the VE?
Yes, as she is examined 4 months back, so I need to examine her in preoperative ward round to assess her condition, and her abdominal examination to um, assess the size of fibroid, and also vaginal examination to assess that whether the size is increased or any other findings she has.
Okay.
mm,
So it will be
and
essential, yeah. So just remember that you will say that you will do the PE, and even just before starting the surgery inside OR, before the patient will sleep, she should be examined by the consultant. You know why? To
mm,
decide that this pathology is still there and what is the most suitable route of the surgery. Okay.
mm,
So these are important. You must have seen the consultants if you are practicing OBGYN, that
mm,
your consultant, they will do the VE just before the exam. Even if you are doing an emergency cesarean section, you are required to do that. And even if you are going for any surgery, you should be doing that. Okay, that is one thing. Okay.
before.
Yeah, before, just before the patient will be under sleeping, before the patient is just lying. Okay. So
Mm,
we are just preparing her. Once we have cleaned her, then if you know, they will start the induction, like she will be inhaling the gases. Okay, at this point, with consent of the patient, that can we see you for one last time? Okay, at that time we do VE once more, because you know
mm,
what happens, that these patients, they have been examined like 4 months ago, right? So we are not sure that the pathology is still there, and
mm,
maybe the size has shrunk, maybe the patient has been given some medical treatment, maybe some changes have occurred, because as we don't know that who is going to develop the fibroid or something. Similarly, we
mm,
don't know that who is going to shrink them, right? Because they
mm,
have these fibroids, they have estrogen receptors on the surface, so they
mm,
can increase in size, and once there is deficiency of estrogen, they can decrease in size. So maybe you planned that you will do the abdominal myomectomy for some patient, but the fibroid has undergone this shrinkage, and now you can go for the vaginal route. So
mm,
you need to do that. And similarly, in the emergency obstetric cases, you need to examine the patient just before the surgery, because the thing is that most of the sections, late second stage sections, are done if there is failure to progress or if there is fetal distress. Okay. So, and
mm,
usually it will occur in the later part of the labor. So patient is fully dilated. So maybe sometimes due to stress, something, she will have like stronger uterine contractions, and then she can push the baby. That is the reason behind it. Okay. So see
mm,
that we do, how much do we need to push the baby upwards if the head is stuck, and do we need to do a transverse incision, or we should be doing the longitudinal incision. Okay. And in
mm,
many cases, you must have seen that the baby is already crowning by the time we are going for the section, because you know, decision to delivery interval, even if you are running, you are very fast, it is never
mm,
less than 20 minutes.
mm,
So in
yes.
OB, just remember, for your safety, things
Mm,
will change in minutes and seconds, not in hours. Okay?
mm,
So be prepared to deal with any kind of emergency or any problem.
mm,
And
okay.
always do the abdominal examination. If you want to practice OB-GYN and you want to stay safe, these are my tips for you. Always
Mm,
do the abdominal examination, and always do VE before you start any surgery. In OB or gynae, you will never see any difficulties in sure. Okay, dear. So, possible advantages and disadvantages of myomectomy for her.
advantages are that relief of the symptom um, of fibroid, and her quality of life will be improved, and increase chances of successful conception. And also disadvantages is that this she's going for the surgical procedure, so risk of surgery and anesthesia, and uh, particularly with the myomectomy disadvantage, um, placental localization problem in during pregnancy, and hmm, so previous history of myomectomy. She can deliver vaginally always. Doctor. Any effect on delivery because of myomectomy?
Yes. What will be that effect?
Mm. So if cavity is breached, then she can deliver vaginally. So this is the
Yes, you should
disadvantage.
mention, yeah, what are the benefits, what are the problems for her? Because, look at her. They didn't tell you that she had previous two pregnancies, each with early miscarriage. So it means that the uterus is, enlarged to the level of the umbilicus. So what will be the benefit for her?
Benefit for her, increase success rate for her conception. She can conceive successfully because implantation, it might be fibroid is hindering the implantation. So because of this, she has a history of miscarriage. So after myomectomy, increased chances of implantation and successful pregnancy.
Okay.
Mm,
So this is very large fibroid, right? There are
mm,
certain advantages, certain disadvantages. Advantages are that she should be able to conceive, and
mm,
the disadvantage is that this is a very large one. So if she will have any problem, anything, she will bleed, she can undergo hysterectomy, because once this is a huge fibroid, she can have hemorrhage. So we are consenting her that if something will go wrong, we will have to go for hysterectomy if we cannot control the hemorrhage and the things. Okay, so there are advantages of all interventions and there are disadvantages of all interventions. So we need to mention all of them like that.
mm.
Okay, so that is one thing. And then practical measures would you arrange for her regarding pre and post operative care?
So because she is at a higher risk of bleeding, so hemoglobin should be maintained in normal
Mm-hmm.
level, and blood is cross-matched and available, and discussion for the hysterectomy and appropriate informed consent will be taken for that, and and also the facilities of intraoperative cell salvage,
Yeah.
interventional radiology will be there, and should be discussed with the patient.
Yeah.
And also the large fibroid, so it could be possibility that surgery might be difficult, and increased chances of damage injury to the surrounding structures. So in pre-operative period, we can
So
uh,
name the surrounding structures. What
surrounding,
surrounding structures can be damaged?
yes, so ureter can be damaged, and
Mm-hmm.
also the ureter, or if any previous history of surgeries, then surgery might be difficult because of adhesions.
Mm-hmm.
So the period, so we can offer the patient the scans or intravenous urography to see the
Map out
ureter
the ureters, yeah. So can
post.
there be any vascular injury? Can there be any intestinal injury? Injury to the other blood vessels like aorta, inferior vena cava? Okay.
Period
So mention
and
all of these things. Whenever you're mentioning abdominal surgery, mention
all
ureter, intestine, and the
intestinal
blood vessels.
blood vessels. And intraoperative period, the surgery will be we have to very cautiously, surgery will be meticulous, and also uh, and always we need to keep an eye on the ureters. Always it will be peristalsis will be checked, and always away from the surgical field. So these are
Yeah.
the
And map out the track, and you should put the general surgeon and the urologist. They should be on alert that we may need them. Okay, because when the ureter is when the fundus is reaching the umbilicus, it means that it is 22-week fibroid. Okay,
Hmm.
alert blood bank and cross match the blood. If the
Hmm.
patient is not already bleeding or anything, or she's at low risk of bleeding, then we are doing only group and save. But once
Hmm.
the patient's risk of bleeding is very realistic, then we are cross matching. Okay, so 4 units of blood should be available, and the
Hmm.
patient should have consented that she will accept blood transfusion. These
Hmm.
are the things. Okay. Yeah.
Hmm.
So, and the need for, if the need arises, she will go for hysterectomy. That is also one of the options. Okay.
Hmm.
And then sometimes we need to tell her that they can regrow. Or nobody
Hmm.
can guarantee that the fibroid will not grow again.
Hmm.
Okay.
Okay.
So warn her what to expect in the immediate post-operative period.
Okay. So, um, I'll explain to the patient that in immediate post-operative period, she will once she will recover from anesthesia, she may feel dizzy up till 24 hours.
Mm-hmm.
So, and also there is a there might be possibility that there is some tube in her drain in her abdomen to drain the blood or excess of any fluid, and also urinary about the urinary catheter, and also about the intravenous drips, and so I will counsel the patient regarding this.
Yes, intravenous fluid. She will have
Mhm.
pain. She will have to stay NPO. She will stay. She will be. The urine will be clean. Urine will have to be drained by the pipe like that. Okay, so that is
By the
one thing. And if she sustains any injury, then she's going to have it for longer periods of time with her.
for longer
Okay,
period.
and she will get good analgesia, and she will be staying NPO for a while until the bowel sound have returned. But she can tolerate. If she can tolerate, she can take sips of water like that. Okay? All of these things like we do in the ward.
Hmm.
That's all we are going to tell her.
Hmm.
That is one thing. Okay. So, and then in the procedure, when they ask you that what you would like to tell her, you should also mention a couple of other things. Okay. What other things? Like the need for the antibiotics, that we are giving it to everyone.
Yes.
Need for the antibiotics, we will give her, um, this VTE prophylaxis, okay,
Yes.
painkillers. Initially, we will give her opioid analgesics, but then gradually we will wean off and we will give her paracetamol like that, okay.
Hmm.
That is the thing. So when we are telling her about the complications, so then we will tell her that she can have complications due to anesthesia, she can have complications due to the procedure because it is a complicated procedure. So basically they are asking you about the consent, okay. So
Hmm.
anesthetic hazards, risk of bleeding, risk of injury. Then during the operation, the same things. She can have visceral injury, any other injury, so she can have massive
All.
bleed, blood need for blood transfusion. Okay,
Hmm.
and then is a injury to the other viscera, and which may involve help of the other people to fix the things. Okay, so the operation can take longer than the usual. So usually we are telling them that it is going to take like 3 hours, but of course we are able to finish that early, but we have to tell them.
Hmm.
Then in the immediate postpartum period, she will be kept on the recovery unit for an hour or so, and we will observe all vital signs. We will measure the output, and maybe we will have to put some drains inside her body like that. So
Hmm.
we have to mention all of these things, okay?
About
And then she
last.
will be shifted to the ward, and she will receive the routine care. She's expected to stay on the ward for like 3 days, and then we can discharge her, and then we will schedule appointment
Hmm.
6 weeks after the operation like that. Okay, so
Hmm.
you have done the major surgery, this woman is in doubt, so let's say that you were able to do the myomectomy. So what counseling you will give her in the post operative period?
In post-operative period regarding myomectomy.
Myomectomy has been done, why she's has come for the myomectomy in the
Or-
first place?
Hmm.
Fertility aspirations,
Hmm.
right?
Hmm.
So tell her what is the chance that she will be conceiving, when she can try to conceive, and it will
Yes.
be like a shock for her. Basically in the post-op period, you are just telling them that how was the surgery, and how did it go, how was everything. We are just reassuring the patient that you have made the right choice, because this patient, because you had a large mass which was interfering with your activities, causing pressure symptoms and pain. Now you have a better chance at fertility, but you should not conceive in the first 6 months. Try conceiving for it later, and you
Mm.
should continue taking the folic acid. Okay. And another thing would be that if the fibroid is like 22 weeks, so most likely we would have given the incision. Have you seen them doing the myomectomy for the large fibroids?
Mm. Yes.
Yeah, you know that they will go to the fundus, because it will
Mm.
not come out through the by the myoma, these screws, myomectomy screws. So what they do is that they will go to the top of the fundus, cut it into two halves, remove the fibroid, and then reinforce the wall. So actually we have breached the cavity, okay? So she
Mm.
has to deliver by the cesarean section, and most likely it will be a
Mm.
preterm delivery, okay? Why?
Mm.
Because you want to avoid the risk of ruptured
Mm.
uterus. Obstetric
Mm.
care, more frequent monitoring, and she can have complications. Then there is
Mm.
risk of abnormal placentation as well.
Mm.
Why?
Normal.
Because we have peeled the fibrite out, so the surface is going to be irregular. So anything,
Mm.
you don't have to say all of these things. You will mention the things, a couple of things, you are going to be fine. Okay,
Mm.
that.
And
So then,
if cavity is not breached and myomectomy by myoma screw, then pregnancy delivery is by vagina. No need of
if the
cesarean.
yeah, if the myoma was subserosal,
Mm.
then it will be true, right?
Okay.
But if it is intramural, or
Mm.
if it is inside the lumen,
Mm.
submucosal, then
Mm.
anyhow we are going to breach the cavity if we are going abdominally. If the
Mm.
myoma is less than 3 centimeter, then in the first place we don't try to remove that, okay? Because that is just too small to interfere with anything.
Yes.
Up to 12 week size, yes, we can take it out through the vaginal route. More
Mm.
than 12 weeks, we have to remove it through laparotomy, or yeah, laparotomy or laparoscopic surgery. Okay, both are
Mm.
fine.
Mm.
That is the point. So you are going to be good. Then in the
The
end, you say that,
uh,
do you have, yeah?
intramural only submucous we can do vaginally, right? Hysteroscopic
Yeah, yeah. Only
only.
intramural you can do vaginally. And if that is large, why you cannot do that vaginally? Because if you will use morsel rater, you must
Mm.
have seen in the consent guideline on the RCUGs, the same guidelines they are using here in the Ireland as well.
Mm.
So there is chance of development of the myosarcoma. If we will use morcellator and we are cutting the thing,
Mm.
then we are increasing the chance of having cancer. That
Mm.
is okay. That's why we don't want
Mm.
to do that.
And what about UPA,
What
uniprostol
about
acetate, uniprostol acetate,
unipressure?
tetracycline?
Is it? Yes, for the fibroids, yes, you can give.
You can give. Mm.
Can give, and the six within 4 weeks of therapy, the size will reduce by more than 50%. Okay, so this patient, that's why I said that uterus is not to the level of the umbilicus. So still she has time. You would counsel her for the other things, but usually what happens is that the people, they are desperate to conceive. Like she has been trying for the 8 years, okay, and she has two losses. So
Mm.
now she has chosen to go undergo this surgery like that. Okay, that is one thing. So we have to respect the wishes of the woman. So that's why we are talking about all of these things while we have already planned the surgery. Like we want her to take all her chances. If she decides 1 minute before sleeping in the OR that she will not like to undergo surgery and she would like to go for the uterine artery embolization, or she would like to take the ulipristal acetate, then we have to document it. We will fill out with, don't say that you will just return the patient from OR. No, you are writing a form. We call it operation cancellation form. Fill that out, give that to the head nurse, and then you can shift your patient outside like that. Okay, the consent and everything, the law, it is about liberating the patient. Okay, give them the maximum chance to decide and do whatever they want. Okay, we don't have to like scare them, or we don't have, because the patient has to make a free choice. That is the idea behind all of these things. Okay, so after that you will ask her, so now after having discussed the things related to the surgery, do you still like to undergo this procedure? If she will say yes, I will say okay, let's go for it, thumbs up, and I will document everything in her notes. If she is a bit hesitant, what will you do then?
Mm,
Don't reschedule, okay? Just cancel the procedure. Cancel the procedure, okay? And patient will have to go through the loop again. Okay,
mm,
let's go to the next one. What is this? Okay, this is okay. This one is also important. Cervical cerclage.
mm. So in preoperative ward round, then informed consent, risk and benefit discussed, all the same thing with
Hmm.
risk and benefit discussion
You can
and
also say that I can take the patient on board. This process is called onboarding. Okay, you are telling the patient and you are finally asking her points on it, that what she will like to do, what are her views, the final, कि आपकी आखिरी opinion क्या है, you want to go for surgery or you don't.
mm, and to check her ultrasound for the viability of the fetus and natal uh, and also her mm, blood group and
Okay,
anesthetic anesthetic assessment is done full blood count for hemoglobin.
okay.
All need to take history. Preoperative ward round. These things.
कि आप operation से you are going to the ward before, just before the operations, like finally putting their names on the list. So this
Mm,
is someone who is 34 years old. She has been admitted for applying cervical cerclage. So we need to take a brief history from her. Okay. What will you like to ask her about her history? Because as such, we cannot take anyone for the surgery, right? We'll just like to check that we are doing, we are following that. We are trying to implement the WHO safety checklist, that this person actually needs the surgery and she is going to benefit from it. Only then we should be doing any intervention, right?
okay.
So we are giving her the last chance. So take a focused history from such patient, that you will go, you will introduce yourself, you will confirm her full name and age, and then you will like to ask her that I need to, yeah, you have been scheduled for the procedure, but before we book you for the OR tomorrow, I'd like to ask you a couple of questions like that. And this discussion will take place in the outpatient clinics. Why? Because these cases are done as a day surgery cases. So we are not going to keep her inside hospital for longer periods of time. That is one. Okay.
Hmm.
So what would you like to know? Because if we are doing the cervical cerclage, we should have a proper indication for doing it. What do you think?
Yes,
Okay,
proper
because
indication.
without that, we should not be doing anything.
Yes. So I need to confirm her gastric age and
Okay.
education. I will ask her uh, any updated pain, complaint, any infection. Hmm. So to explain and to review her
Okay.
document and
So what
eligibility.
would you like to know about her history?
Her history. Need to ask the detailed history of
Mm-hmm.
and previous pregnancy details
Mm-hmm.
outcome of previous pregnancy.
So you should be very specific. How many pregnancies? What was the outcome? Did she have preterm labor or she had miscarriages?
Hmm.
Okay. Were they painful? Were they painless? Did she
Hmm.
receive any progesterone? Anything? What did they tell her? Why it happened to her like that? Okay. Or maybe she has negative history and things have been identified only on ultrasound.
Hmm.
Okay.
Hmm.
What else you would like to know? Or we are always checking the blood group and the RH factor of all the patients, right? And the hemoglobin level. She is less likely to bleed, but how far she is then the LMP, how far she is into this pregnancy, planned pregnancy or unplanned pregnancy. Did she take any folic acid supplement or she didn't? Okay.
Hmm.
And how far she is into this pregnancy. What is the ideal time for applying the cervical circumference?
Between up till 14 weeks.
You can say that 15, 16 weeks, that is the ideal time. Okay. So usually 15 weeks or the 16 weeks is the most popular period. Okay. Then ask her, did anybody, so what were the circumstances of the previous pregnancies? What was the outcome? Okay. And then you will ask from her that how far she is into her pregnancy. Was any dating scan done? You have to be sure. Okay. And, did they do the ultrasound before booking her for the some circlage? Because at 14 weeks, 15 weeks, pregnancy is viable, fetal heart is there, and the baby is not known to have any congenital abnormalities. You have to be sure of all of these things, then you can decide about going for
Hmm.
the operation. That is one thing. Okay.
Hmm. So we are doing this before anomaly scan, or we do
Yeah.
prior.
Viability scan. Okay. And no gross abnormality, because the congenital anomaly scan we can do between from 18-week onwards like that. Okay. By that time maybe she will lose the or she was would have already lost the baby like that. That is one
Hmm.
thing. Okay.
Also, in
Hmm.
history,
Okay. So
and
then you have taken the history, also asked about any other problems like that. Okay. So,
hmm.
what were the circumstances of the previous pregnancies? What happened? The event and the babies which she passed, were they normally formed or they were diagnosed to have any problems? Okay, and did she have any fever, any history of bleeding around the time of miscarriage or not? Like before that, because maybe the factors are different which are causing it. Has she ever diagnosed with thrombophilia? Does she suffer from any chronic disease? All of this information is important before we can simply just go and put the cerclage like that. Okay. And
Hmm.
so far, the examination of the fetus has shown that the baby is normal. Okay, that is also
Hmm.
one of the things. Then any history of blood clots or the cancers in the family, because we are trying to gauge the risk of this woman as well. Okay,
Hmm.
then does she have any chronic condition? What is her social history? Is she allergic to anything? Just like everything we did for the other people like that, in that cases like that.
Hmm.
Okay.
Hmm.
Okay. Then the second part, take me through the steps of this procedure.
Um, Mac, McDonald record photos.
Okay. Another important thing, sorry, I forgot in the history. Ever applied cerclage on her before or not?
Hmm. Okay.
That is
So
one thing. Because
if
if there
history,
is, Mhm.
then
if, because
apply.
if failed vaginal cerclages, then we will
After that.
have to apply directly abdominal cerclage.
Hmm.
Most likely, so, but we cannot say that she has had undergone some operation like this or not. So that's why we are going to give her chance.
Hmm.
So document you, so you should know about all of these things. So let's say that she is for the simple cervical suture. So usually which suture is applied, McDonald or Shirodkar?
Pirotka,
Okay, so how do we apply that?
that's that
So, yeah, so you will tell me about that. So tell me that you will take the patient to the OR. Okay, her consent is there, and you will do the VE before the procedure. Okay, the bladder will be empty, bed will be up, like the she it can be tilted backwards also. Why? Because maybe because we don't want to prick the membranes. We will take consent for the patient that procedure may fail. Like despite having the cerclage in place, what can happen? Still they can lose the baby, right? It happens many a times, unfortunately.
hmm.
Accidentally, the membranes can be ruptured, and then membranes can be pricked accidentally, and then it may result in cerclage. May result in miscarriage, and she will have to take the antibiotics and the painkillers for next several hours like that. Okay. So how do we do the procedure? You have emptied the bladder. So what will you do now?
After the blood tissue patient will be in the lithotomy position, empty
Mm-hmm.
the and before the procedure, make sure all the instruments are available.
Yeah.
Procedure, how to explain, I don't know. That
What in which position you will put your patient?
lithotomy position.
Yeah. And
Hmm.
we will do the clean the area, and with sterile gloves we are going to do the vaginal examination.
Hmm.
And after that, what you can do the per speculum examination. So when you are doing the speculum examination, what are you trying to look at?
To first look for the vaginal wall, any
Mhm.
and atrophy or erosion, any
Yes.
vaginal wall, then cervix, visualize cervix, signs of
There is no leakage, there is no discharge, no offensive smell, no blood, membranes not bulging through the cervix, okay, and the cervix is long and closed,
hmm.
okay. And if there is any infection, then you need to reschedule the procedure. That is the point, okay, like that. So you have done, things are fine, so you have cleaned the area. So what are you going to do now?
Then
Ensure good light. Ensure bladder is empty. Okay,
That is.
and you can see the walls. You can just put the Cusco speculum inside, or you can just take the same speculum to look at the walls. You will have to introduce two Sims speculums. So that is going to, the assistant is going to do that for you. Okay. Then you will take this Marcelin tape, which is a 5 millimeter non-reabsorbable suture. Okay, we have the best results with it. So there are different ways we are going to encircle the cervix. Okay, so you can go, you can have this 2 point entry, or you can have this uh, how many points? 2 points entry or 3 points. Okay, like that.
Mm,
I will not separate the wall of the bladder. In the short, in the Shirodkar, yes, you will separate the bladder wall. In McDonald, you don't have to do that. Okay, just remember.
okay.
So then you will just go around the cervix and tie the knot at
Mm,
12 o'clock position. After that, I will ensure that I will give cut and give the needle to the scrub nurse. I will ask
mm,
her for the counts and the needle and remove the circlage, clean the area and see that there is no bleeding. And then I will put two Indocid suppositories or 200 mg suppositories per rectum. I would
mm,
have informed the patient that at the time of applying this circlage, there can be slight ooze from the cervix.
mm, okay.
That is also one of the things, right? Right?
Mm,
So you know, these things are very, very simple. But
yeah.
why we are practicing? Because we should tell them during the exam. That is one
Mm,
thing. Okay, so you have done that, you have put that rectally, you have observed that the patient doesn't have any leaking anything, and after that you will remove everything, counts, and then you will tell the person that she is fine and we are not planning to continue it like that. Okay,
mm,
so if they ask you about the Shirodkar, they will not ask you. If they ask you that why we don't do it very frequently, you will say that we have to push the bladder up and then we have to apply a suture, and sometimes the suture may become embedded and then we have to remove that surgically, so it can be a hazard and patient is at risk of exposure to anesthesia twice, once at the time of application and secondly at the time of removal. That's why we don't want to do that.
mm,
Okay, so you have made the diagram, you will keep the patient, and then what you will do, you're confirming the fetal viability just before the procedure and just before the discharge also. That is one
mm,
thing. I will give her erythromycin because this is like going to cover a good spectrum that is helpful. Covers vaginal pathogens as well. So that's why we are giving her erythromycin. And she will
okay.
continue taking prenatal vitamins. Once she is out of anesthesia, you and the bladder will be catheterized, right? Bladder would have been catheterized all the time. So you leave
Mm,
the catheter in place. Once the patient is conscious, you will remove the catheter and you will show her that the baby is doing very well. You will schedule an appointment with your consultant and discharge the patient. If she will have any questions, you will like to answer them. That's all you need to tell them. Okay. So, so these were your post-operative orders like that. Okay. Schedule an appointment, invite questions. Okay. And that's all you need to do for this patient. Any other problem, anything for this case?
So in risk of failure of the large risk
Yeah.
of rupture
Yeah.
of membrane.
Infection, erosion. And also, you have to tell her before applying the suture that when we will remove it like that. Okay, so usually we are removing at 37 weeks. Like once the baby is mature, then we are going to remove it. Anything else that you would like to mention for her?
No, it's done.
Okay. Okay. This one. This one. Just go over this one. You know, if they give you a station like this, like which has multiple parts, keep your left finger on the question that you are answering.
Okay, to remember uh, how much I have covered.
Yeah, that which one you have answered and which one you need to answer.
Hmm. Okay. So this patient has
Okay.
urinary stress urinary incontinence, and she had tried physiotherapy with
Mhm.
minimal, and she has been seen in gynecology clinic 6 months back, and now she is for corpus suspension procedure
Mhm.
next. So in pre-operative ward round, I will introduce her by my name and my role, and need to confirm her name and age and hospital number. I need to confirm that the procedure is explained to the patient and she knows regarding risk and benefits of procedure, and informed written consent is taken, and consultant review has done or not, and anesthetist assessment and all the investigations required by the anesthetist is available and attached in her documents, and full blood count for hemoglobin, and according if she is in reproductive age group, then pregnancy test is done and pregnancy is excluded. And
Okay.
procedure will be done under WHO safety surgical checklist, and enhance make sure I will ensure that enhanced recovery program is followed, and need to take history regarding her symptoms also, that because she has seen 6 months back, so need to confirm regarding her symptoms, whether symptoms are still bothering her or any new symptoms she has. And I need to know her any medical illness she has, whether she is taking any medicines which needs to be stopped before the surgery, and like any combined hormonal contraceptive or any anticoagulants or hormonal replacement therapy, and any allergies she has, and need to know previous surgery detail, like any abdominopelvic surgery or any urogynecological surgeries has done before, and her reservation for blood transfusion need to exclude, and also her detail regarding her support at home, and also her mental history is important. I need to know her body mass index and her social habits like smoking and alcohol.
Okay. That's wonderful.
Hmm.
Okay. So go to the next part of the station.
Next part is pelvic examination.
Mm-hmm.
So the patient is examined 6 months ago, so I need to examine her with her permission in front of chaperone to
Mm-hmm.
assess her findings. Uh, uh, like I need to confirm that the findings is still she has same finding, or she has developed another um, finding
Communication. Something like that, yeah.
complications or complaints she has. I have to explain the finding, abdominal examination, vaginal examination.
You will just say that I will confirm that she still has the same things, because even when they are this patient didn't have any benefit of physiotherapy, anything, right?
Hmm.
So you have to see that still the prolapse is there and she is having the problem like that. Okay, and the walls are atrophic. Here they didn't tell you the age of the patient. Okay, so like all other cases, that's why we would like to confirm the name of the patient and age of the patient, because
Hmm.
then you will know what exactly she is going through, what is the extent of her problem, okay, what is the effect on quality of life. Just say the right words, because the examiners are looking for these words. Okay, what is the
Hmm.
impact on her quality of life? Is she able to continue doing her routine work or not? Some patients, they will leave the job because of the embarrassment, okay, or because of the hassle they have to go through. That's why you have to confirm everything. Pelvic
Hmm.
examination, yes, you will do. Why? Maybe she has developed a new complaint. Maybe she has a cystocele and now she has developed a rectocele as well. Okay, so
Hmm.
it is. It may. It. You can also say that you will not do the examination right now. If he consents for it, okay, we will do. But anyhow, we have to do the examination once before the surgery inside OR as well, like that. Okay. So
Hmm.
you will say no. They will ask you why. Then you can say, you will come across all types of examiners. Okay.
Hmm.
If she says that why you should not be doing the exam, you will say because anyhow before starting the procedure we have to, once she is put to sleep, then we have to examine her. Another one would ask you why you will do the examination to confirm that she is having still having those structural abnormalities, or she has developed a new complaint like that. Okay. More
Hmm.
importantly, she is not having any infections down below. Why? Because if she is having infection, then we are not going to do any procedure on her. That is the point.
Hmm. So here, I not to tell examiner, like in pelvic examination, that I will look on the vulva or the cuff on leak or any prolapse. So I need not to explain here in this case, please before the surgery.
Yes, you need to
Hmm.
tell her like that. Okay.
No, if you ask me that pelvic examination on her, what do means this question, second question. So I have to explain all the things, like I need to see I would like to examine her in preoperative period, because I need to see that whether she has the complaint is still there, and any other complications we develop. So I need to take see her inspection on
Yeah,
are doing all the thing, inspection of the vulva, then inspection of vagina and the vaginal examination of the prolapse.
yeah.
All the things I have to mention, or only I have to say
No,
like
no,
this.
you will mention.
To
You will mention. Fatma, this question. I had one very brilliant girl. She is working in Ireland. Okay. So there was one very fussy person. Okay.
mm,
So he asked her, what will you do for the same patient? Word to word, that's what she told, and I made a question on that one. So he asked what procedure you will do. She said that I will repair the anterior cystocele and I will fix the bolt. I can do like sacrohistopexy. He said, no, tell me the name of the procedure. He
mm,
was after her. What is the name of the procedure?
mm,
Sometimes, in the Irish exam, you can get people like this. You will not have this complication when you are doing the RCUG exam. But in the
mm,
RCPI sometimes, this time you are sitting from Oman, so you will not have this problem. Sometimes very old fussy people, they will come into the exam. Okay, they'll want you to mention 101 things about the same thing, while you're not going to factor them in when you are talking about the management like that. Okay. So this
mm.
one has a prolapse, moderate cystocele, no other gynecological pathology. So, what are you going to do for her?
Vaginal prolapse and moderate cystocele.
Hmm.
So I will ask in history regarding complaint, her urinary complaints and difficulty in passing urine. And
Yeah.
also for the um, and for the surgery, so we can offer her anterior repair for the cystocele.
Yeah,
Hmm.
that is the thing.
Hmm.
So, what surgeries can be done for this patient?
For the cystocele anterior repair,
Mm-hmm.
and she's for stress urinary incontinence. She's for colpo suspension. So abdominal colpo suspension, either laparoscopic open,
Mm-hmm.
hmm, will be done.
Yeah.
So both the
Thing.
both complaint uh, can deal at the same sitting.
Yes. So you will say, I will tell her that surgery is performed vaginally and it will involve lifting the prolapsed neck of the bladder into place. We are going to lift it into the place and using stitches and removing any excess vaginal tissue like that. Okay. And it is going to increase the support for it like that. That is one thing. Okay. And the uterus is prolapsed, then you will say that this anterior prolapse is associated with the vaginal prolapse also, prolapse uterus also. So once we will fix it, and you have to see that what is the age of the patient and does she have any fertility aspirations or not. Okay. If she
Hmm.
is an older woman, postmenopausal, then she has no function left for the uterus, and the prolapse is significant because they said like moderate cystocele, and they have not told you that she has sensation of prolapse. So if
Hmm.
on testing the prolapse is there, then the treatment of the prolapse in the older woman is that we should go for hysterectomy, right? If she
Hmm.
doesn't want this hysterectomy, then what can we do for her? Then we can do the second hystropexy, okay, which can be done in several ways like that.
Hmm.
Then if this one she is incontinent as well, like that, okay. So
Hmm.
they can do certain procedures like the for the prolapse we said that we are going to put fix the vaginal wall. If he is having incontinence, then you should say that we are going to do some procedure after numbing the area, like you will be sleeping, and we are going to do some procedure to support the urethra or
Hmm.
to support the urine pipe. We are going to do some procedure to support the urine pipe. So this
Hmm.
is urethral suspension. Okay. So here
Hmm.
you are not doing two procedures. You are going to do urethral suspension. You are going to remove the redundant tissue. You are going to do the anterior repair because this woman has got a cystocele.
Hmm.
Then the third problem is that she has uh, a sensation of vaginal prolapse. Okay, so maybe she had a history, some hysterectomy, something before. We need to confirm that. Okay, in the
Hmm.
genetics one when she was listed for corpus suspension. So she is for corpus suspension. So corpus suspension she is having. So maybe she underwent hysterectomy before, something like that. Okay. So we need to see that she is having the vaginal prolapse or she is having the uterine prolapse. Uterine prolapse, the treatment would be we can do the hysterectomy. If it is only uh, the corpus suspension means that there was vault prolapse like that, vaginal prolapse. So we can do different procedures like we can do the sacrospinous suspension, vaginal sacrospinous suspension. Whenever you will take name of one procedure, you need to tell them about the complications, need to tell about them about the benefits. Say abdominal sacrocolpopexy, that is much better, can be done through laparotomy or laparoscopically. Longer procedure time of the procedure, but longer operation time, but physiological access would be maintained and the need to stay in the hospital is short, and also the risk of reoperation is also low as compared to vaginal sacrospinous fixation, right? So mention all of these things. So she has already been admitted for corpus suspension. We can do through different routes. We can do abdominal sacrocolpopexy or we can do vaginal sacrospinous fixation. Tell her about the risk and benefits of both. And then after that, you can say that I will ask her, I will tell her that we will have to keep a pipe inside her bladder to drain the urine. She will have to stay NPO till she is out of the effect of anesthesia. And since you have done everything vaginally, we have not manipulated her bowels, so we don't have to keep her NPO or anything. Once she is conscious, she is able to move, so she can start taking the sips of water. We will give her good analgesia, good hygiene, antibiotics, and sport. And if she will have any questions, we are going to support her in that, like that. Okay, that's all you need to tell her, like that. Any questions, any problems you have?
Hmm. In corpus suspension, what suture material they use?
Yeah, we are using delayed absorbable sutures. Sometimes basically non-reabsorbable sutures because we are going to fix it somewhere. And usually what are we doing? We are just holding the vault and fixing it to the anterior longitudinal ligament. So since we are not attaching it to some other viscera, so no chance of developing any sinuses, anything like that. They will never go into such details because this one is a mid-level specialization, this RCPI courses like that, exam like that. So just say the right things and you're going to be fine with that. Okay, that is one thing.
Hmm.
What is this case? Laparoscopic sterilization. On laparoscopy, yes, they can ask you. What is this one? Can you put your word rounds? Okay. It is their favorite question. This should be on your fingertips like that, okay? The steps of vaginal hysterectomy and the steps of abdominal hysterectomy.
Hmm. For abdominal hysterectomy,
Yeah.
what will you like to know before her further management? Hmm. So, patient is 48 years old, para 6,
Hmm.
and she has a persistent complaint of menorrhagia, and she is willing for definitive treatment. So, I will introduce myself with my role and need to confirm her name, age, and her hospital number. I
Hmm.
need to take uh, history from the patient regarding her complaint, since when she has menorrhagia, and whether it is affecting her quality of life, and what treatment she has taken so far, and what are the whether the treatment was effective or not. And
Okay.
I need to know that since when she has an menorrhagia, any symptoms of dizziness, symptoms of anemia, shortness of breath, and also regarding her when was the last menstrual period, any intermenstrual bleeding.
Hmm.
The menorrhagia is accompanied by dysmenorrhea, and also need to ask her cervical screening and when was the last one, and regarding the results of the cervical screening. And I need to exclude the pregnancy at this moment, and also whether she is taking any contraception, and need to ask regarding her sexual history, any complaint during sex like dyspnea, postpartum bleeding, or any discharge. I need to ask regarding any sexually transmitted infection in past, and her obstetric history in detail, and how many deliveries or pregnancies she has, and what was the outcome, and recovery after that, mode of delivery. and what is her future fertility plans, and her surgical history, any abdominal pelvic surgeries, and also her medical history, any medicine she's taking, any allergies she has, her body mass index, any reservation for blood transfusion, her social habits like smoking, alcohol intake, and how is the support at her home, and regarding her mental history is important.
Yeah.
And also need to ask about symptoms, um, any symptoms to find out the cause of menorrhagia. I need to ask any thyroid symptoms she has, and any medicines she is taking, like anticoagulant, any bleeding disorders. Need to exclude all these things.
Yeah.
And now she is for definitive management for the abdominal hysterectomy. Um, for the procedure of abdominal hysterectomy, the procedure will be done under WHO safety checklist. And before that, only procedure, or is to the point, like not in preoperative period,
Actually,
right,
you
Dr.?
should say two things, okay? Obliterative surgeries can be done, no, no, no. This one is hysterectomy like that, okay? So you will have to tell the steps also. And before you will go to the steps, you need to be sure that she knows that what exactly she is having and what type of treatment can be given for her like that, okay? So you will like to know that she has been given information about all of the things, okay? And then,
Hmm. Yes, before surgery, I need to confirm that patient has explained other treatment options like
mhm,
medical treatment, and medical treatment is explained to the patient, or other non-invasive procedure like endometrial ablation is discussed or not. And also, before the procedure, need to discuss regarding the removal and preservation of ovaries. That if the ovary is removed, then we need to give her hormonal replacement therapy. And if risk of the preservation of ovaries, that there is a risk of future ovarian cancer, or and in future any surgery for the removal of ovaries can be difficult because of the surgical adhesions. So all these risks and benefit will be discussed in preoperative period, and need to confirm that an informed consent, written consent is taken. And so during the for the procedure of abdominal hysterectomy, patient will be anesthetized, and the incision will be made. Transverse incision is preferable, and after the incision, abdominal cavity will be entered, and once it will enter into the abdomen, the retracted, bladder is retracted, and bladder is retracted, and make sure that no any bowel caught under the blades. Then the first is a two straight clamp will be applied at the side of the corner to stabilize the uterus, and two curved clamp is applied to the first pedicle, which is the round ligament, and the clamp is applied. Then pedicle is cut and ligated,
mhm.
mm, and transfixed to avoid any slippage of the suture. And the same procedure will be done on the opposite side. And so for the next step, Next step is the according to the like this is for the abdominal hysterectomy. So next is the ovarian ligament. So clamp is applied and with the ovarian ligament and cut and ligated, and all
Mm-hmm.
the procedure with the help of assistant, and the same will be done on the opposite side.
Yeah. So you are going to cut them bilaterally or unilaterally, the ligaments and the thing. So you should say on both sides like that. Okay.
On both sides. Hmm.
Yeah.
On both sides. So at this point, I will make sure that ureter is away from the surgical field because it lies in the ovarian fossa.
Mm-hmm.
For the next is the uterus and the cervix is separated from the bladder. And at this point, if the patient has any previous history of surgery, so this step can be difficult. And if any difficulty, I need to involve my consultant. And if any injury is suspected or any injuries occur, then need to involve the urological specialist.
Yes.
Next step is the, uh, I will skeletonize the uterine artery, and at this moment make sure that ureter is away because it lies below the uterine artery. So uterine artery needs to be clamped um, with the help of a curved crushing clamp and cut and ligated and transfix double ligate to avoid any uh, slippage, and same procedure will be done on the another side. And the next is the uterosacral and cardinal ligament. So it will be clamped by the straight clamp, two straight clamp, cut and ligated and transfixed to avoid slippage. Same will be done on the another side, and the uh, thread will be keep long, um, and it will be tied with the vaginal vault thread to avoid the future for wall prolapse. So after that, vagina will be separated from the cervix, and it will be cut, and sample will be handed over to the nurse for histopathological examination with correct labeling of name, age, and hospital number. And after that, vaginal vault will be closed with continuous non-locking suture and make sure hemostasis is secured. And then it will be tied with the uterosacral ligament thread to avoid any future wall prolapse. Then all the pedicles will be checked for any hemostasis. Uh, urinary bag will be checked for any hemorrhage, and all the count or stop will be confirmed. It is complete. So, so this is how. Next is the closure of the abdomen, and peritoneum will be left unstitched to avoid any post-operative pain and morbidity. And abdomen is closed, and the subcutaneous tissue will be is closed if more than 2 centimeter fat subcutaneous tissue, and then skin is closed uh, with the stitches
Mm-hmm.
subcuticular. So these are the steps. So in post-operative, the patient will be in the recovery room, and the observations will be monitored with adequate urine output. An appropriate analgesia will be done, and appropriate documentation will be done. Appropriate documentation will be done, and patient will be given a plan for the follow-up with the histopathological examination will be done. And once the patient is settled, then shifted to the ward, and her observation will be done on eye muse chart with appropriate input and output measurement, and venous thromboembolism risk assessment will be done, adequate hydration and early mobilization. So how much means if the question is describe procedure, then I will describe only procedure, not
Yeah, the procedure, because they want you to tell them that what exactly have is the structure that you are going to cut, and which blood vessel is at risk of bleeding, like that. Like children, they want you to tell them this will be the first step, this will be the second step, and this will be the third step, like that. Okay.
So like here is it in describe procedure, then I will also only describe procedure, not the post-operative.
Yeah, but you should, to gain maximum marks, you should just say something like that. Okay.
And
Post-op care, that she will have to stay there for some time, and
what instruments you will use
yes, instruments, no. Instruments, they will only ask you to identify, like nothing else.
to identify. So in hysterectomy, which instrument, which
Instruments, they will never ask you, only instruments on the skills station. Like I will also give you in the circuits that tell me that which is this circuit, which is this instrument, and what is the, how do we use it, how we hold it, like that. So what are the indications for using this instrument, like that? That is the thing.
hmm.
Okay.
So how many instruments they are keeping usually?
Just two or three.
Two or three. So if hysterectomy instrument is there, then most probably that one which we are applying on uterine artery.
Yeah, simple one. Don't worry about that. On your web page, you have a full list of instruments. Like there are 60, 70 pages, but don't be scared, because big pictures are there. It takes hardly an hour or two to go over the things like that. So don't
I
even
think
worry about that.
in on not on my page, because I can see only few things like
Okay.
uh,
You,
okay.
they are not on the page. Okay. I'm sorry
Hmm.
about it. Let me check again. Okay. Because so many pages, because people, they keep coming. Let me check. Okay. And I will ask
Hmm.
them to send the um, links for that one also as well. So just tell them about the immediate care and how you will arrange that, and you're going to be fine, like that.
So for
Hysterectomy,
uterine,
I'm telling you. Yeah,
so
please ask,
for
say.
uterine artery, uh, curve clamp, crushing clamp.
They will not ask you about the name. They will just ask you that which is this instrument, myomectomy clamp, sim speculum. It will be something very simple, not like RCOG. They will not bring like in the MRCG part 2, they will sometimes give you the pictures of instruments.
Hmm.
Remember that, label them. Which one is lace clamp? Which one is like the
Hmm.
Alice forceps? Which is this one? The Babcock forceps, like that. So the Irish, they are not like that. Okay?
Hmm.
They can give you a
No,
green armitage. They can give you some uterine sound. Okay, they can give
hmm.
you tenaculum forceps. Sim
Hmm.
speculum, they are giving, sometimes they are giving Cusco speculum, something which is like very big, and you can identify it quickly, because as such, they are not trying to fail you, they are trying to pass you.
Hmm.
Especially the short cases, they are going off the way to help you only. The only problem occurs during the long cases where they don't support you much. In other things, no problem. If you are doing good, they will go off the way to support you.
Hmm.
That is the point. Okay.
Hmm.
So can we go to the OB surgery for a bit now?
Yes.
Hysterectomy, remember, hysterectomy, they are going to ask you in one way or the other. Okay.
Hmm.
Here is your first case. Shrink that one. So we are doing the obstetric surgery. Okay. This is your first case.
In exam, the questions, I will wait for the examiner that he will say question or not.
Mm-hmm.
So they are going to say question or
They will
they
ask you the
remain
questions.
will
You
ask.
know, the main three headings, they must have written like main three questions. But like I told you before, in between these three main questions, they will ask you about some small questions.
Hmm. Major to so first question. So she is primary gravida for elective cesarean section for major placenta previa and the fetus is in breech presentation and currently she is at 36 weeks of gestation. So first question is preoperatively what will you discuss with the patient? So
Yeah.
in operative period, I will introduce myself with my role and need to confirm the patient age, name, age, and also hospital number. And I will discuss with the patient regarding the procedure, detail of the procedure, what is the purpose of procedure and what she expect uh, during the procedure and after the procedure. And I will discuss all the risk associated with the cesarean section regarding risk of the surgery and anesthesia. And also, she has a major placenta previa, so I will discuss with her regarding the risk of bleeding and risk of hysterectomy. I will explain, and so and for the baby. And also, I will explain the risk of surgeries, that the risk of pain, infection, bleeding, and the major risk is damage to the surrounding structures like bowel, blood vessels, and bladder, ureter. And need to explain that the surgery can be difficult because of the placenta previa, and also I need to so during the preoperative period, I need to confirm regarding the her previous obstetric history, any previous surgery to exclude the risk of placenta activa, and also need to explain all the risk and make sure that informed consent is taken. And I will discuss with her need of the transfusion. So, Prasha, discuss the preoperative means preoperatively or means a discussion with the patient. And so I need
Yeah.
not to include history,
No, no, no.
only
History,
only risk.
because you know, yeah, history elective section because she has major placenta previa. So you just need to
Hmm.
go, and she is currently 36 weeks. Okay, so you need to ask just a couple of things. That um, how many children before, because you would like to see that how much is her risk of having the complication. Okay, any surgeries before, because some of the questions you will ask them, they will be according to the previous history of the patient also.
Hmm.
That is the reason. Okay.
Hmm. So, no, if the specific question is that what will you discuss with the patient?
Yeah.
Uh,
So
so in that,
basically,
include
yeah,
history or only risk discussion?
yeah. So basically, you are consenting your patient, right?
Okay, okay.
That what complications we can have during this procedure?
Hmm. So, for the complication, just I mentioned all the risks associated with anesthesia and risk of hysterectomy, risk of bleeding, and also risk of baby. Like baby might require an ICU admission, and also need to discuss with the patient regarding the previous surgery detail and also her obstetric history is important and need to discuss any reservation for blood transfusion she has because she is at increased risk of bleeding and might require blood transfusion. And
Yeah.
also hmm, and also I will discuss with the patient the option of intraoperative cell salvage and explain that regarding the interventional radiology, and these options will be explained and discussed. And so these
Yeah,
are
basically, you are going to consent her for the cesarean section and also for the peripartum hysterectomy, cesarean hysterectomy. Okay. So the consent guidelines just mention a few things. What is the risk? What type of surgery we are going to do? Why this one is very serious, and how we can make it safer for her.
hmm, hmm, okay. And what other personnel will you liaise with? Yes,
Yeah.
so this patient require multidisciplinary team approach. So a senior consultant and senior anesthetist will be there at the time of surgery, and hematologist, blood bank laboratory, all involved, and neonatologist, an intensive care unit and high dependency unit will be involved in her care. And so, and in case of any emergency, interventional radiologist, vascular surgeon will be involved. So, preoperatively, order? What will your orders be? Preoperatively, will blood count for hemoglobin, blood group, cross match, 4 units of blood,
Okay. 4 units or 6 units?
4, 6.
This
Okay,
is placenta previa. Okay.
okay, six
So
units,
6 units.
six
Six
units,
units
and
of blood, 4 units of fresh frozen plasma should be standby, and 2 units of the cryoprecipitate. Okay, this is what
so
we.
so I was reading that for the fresh frozen plasma they are using, or they are saying the solvent detergent plasma.
So they don't have to bring it to the OR. The blood should be inside OR. Like we will keep 2 units with us, but rest of the things should be available inside blood bank. Okay, like that. So you will apply placenta previous 6 bundle, right?
Placenta previa. Yes.
What is that thing?
The consultant obstetrician, consultant anesthetist should be in the operative suite at the time of procedure, and make sure that an ICU level 2 critical bed is available. Hematologist and blood bank facilities is available, and blood and blood products is available, and patient will be counseled regarding the risk of hysterectomy, and informed consent is taken, and discussion and availability of intraoperative cell salvage and interventional radiology is available and discussed with the patient. And hmm, and in case of any hemorrhage, postpartum hemorrhage, then early recourse to the hysterectomy by after opinion of two consultants.
Yeah. So the next part.
Preoperatively, it is done. No? Preoperatively, what will you order? The same thing, no? Which we have discussed. Take me through your operative procedure and outline any concerns. Hmm.
Okay. So I have a one question for you. Can you apply the principles of enhanced recovery program here as well? Why
Yes.
not? We will apply, okay? You will follow the
Enhanced recovery.
principles of enhanced recovery program. Like that.
Enhanced recovery
Basically,
program.
that's for gynae, but is useful here as well.
Hmm. Okay. So for the operative procedure, so during um, ultrasound facility will be available to confirm the site of placenta, and it will provide information on the site of incision. So,
Yeah.
hmm. So I have to take through from the abdominal incision all the operative procedure.
Abdominal procedure like that, okay? Abdominal. That is, and then there, remember there can be other problems as well. What can that be?
Any
Because
concerns?
you're doing a cesarean section right now, right?
Hmm,
For the for this one. So you will say that you will try to cut it, the consultant will be there or the senior trained person will be there. You will try to cut away from the placenta at a size, cut inside the uterus at a site away from the placenta. But if it is not possible, you will cut through the placenta. You will give a longitudinal incision. Okay, that is one thing. Because our understanding is, I know that in practice we give transverse incision, but ideally you have to give the longitudinal incision so that you will have enough space and you, because our understanding is that in placenta previa the lower portion is occupied by the placenta
listen.
and the baby is usually in abnormal presentation lying above the placenta.
Hmm,
That is the reason, so that we can take the baby out easily.
hmm. So vertical incision, you are telling about the uterus,
Yeah.
hmm. And
Yeah.
abdominal is transfer. Hmm,
Abdomen, you can they say that better to give the longitudinal incision. Why? Because you will have more space to manipulate. Because you know what happens in such cases is that if the patient has severe bleeding or something, then we are increasing the space. So better to give the longitudinal on the abdomen and longitudinal on the uterus. But it is up
hmm,
to the advice. Okay, we can go in both ways. That is not going to affect us actually, but the incision on the uterus that matters more for us.
hmm. So if it is not possible to avoid the placenta,
Then cut through
then
it.
okay. Hmm. And anything else in this uh, operative procedure?
Rest of the things are fine. Then you should say that you will deliver the baby. You will see that placenta is, they said placenta previa, but we don't know that placenta is accreta or not. How we can know that? We should, like we missed one point in the evaluation before. So when we are doing the ultrasound, it should be done by some expert. They should see that this is not a case of placenta previa accreta. Okay,
Hmm.
and the previous
Hmm.
history of the patient is also important, that how many times surgeries he has before, and is there what are the chances that placenta has grown through the muscle or the serosa of the uterus. Because if you're
Hmm.
fighting with an evil, you should know that how big or how bad is that scenario. Okay, so prepare for the worst scenario. That has the
Hmm.
placenta gone into the bladder, has it gone into the posterior abdominal wall, God forbid. So we should know that. Okay, if we don't find the answers on ultrasound, then we have the option to go for MRI.
Hmm. Okay.
Okay, so we should know accurately that how bad, that what type of placenta previa we have, and is it only placenta previa, or this is accreta, increta, or percreta.
Hmm. Okay. Hmm.
Okay, so these
Hmm.
are the things, and then you will say that you will see after removing, you will see that the placenta is coming off or not. If it is not coming off, then you will see that is it adherent or not. You will try
Hmm.
to take that in the piecemeal, and you would have consult the patient. So we can use the tamponade method, like we can put the Beckley's balloon, active management of third stage. If the placental bed is bleeding, then I will like to keep Beckley's balloon there like that. Okay, I can take the hemostatic sutures into the placental bed to arrest the
Hmm.
bleeding. If that doesn't work, you will give the tamponade effect, and you will not close the uterus. You will see that is there any difference in the blood flow, rate of blood flow after this compression effect or not. If the bleeding is controlled, then we will just suture the uterus carefully and come out.
Hmm.
If this is not the case, due to tamponade nothing is happening, then you will try to ligate the uterine vessels on that side, on the side of the placenta. Not working,
Hmm.
then you will try to ligate the ovarian also. That is not working, then you will go for the iliac, anterior division of the iliac artery. So what do
Hmm.
we call this procedure? Like you try in ovarian, internal iliac, and then in the end placenta can be compressed. What do we call
This
this
one,
procedure?
devascularization,
Yeah, stepwise demuscularization. We will go
stepwise
for it.
Hmm.
So if the bleeding stops, okay. If the bleeding doesn't stop within half an hour, then you will take opinion of the second consultant and you will proceed for cesarean hysterectomy. That's why we take consent from the patient in the start. They are giving you
Hmm.
the worst scenario that she is 31 and she is primigravida gravida and she has a placenta previa.
Hmm.
All of these are bad things, right? And remember how the primigravida gravida can have some problem, because if he had PID, if he had fibroids, or it can be idiopathic as well. Like we don't even know that what is the cause, but it has happened like that. Okay. So operatively, what will you do?
Post-operatively, patient will be in the recovery room so to monitor. Once she is stabilized, then she will be shifted into the high dependency unit and intensive care unit, and appropriate documentation will be done, and
Hmm.
appropriate post-operative care will be
Yes,
mentioned, and
you will
nursing
write
staff will.
post. Yeah. Post-op
Mm.
orders will be very accurate. So, what would you like to tell them?
So nursing staff will be instructed for the care, and patient observations will be monitored on IMU's chart, and appropriate input of the fluid and output measurement will be done, and venous thromboembolism risk assessment is done. Patient will be provided for the appropriate compression stocking and appropriate hydration, and early mobilization will be done, and adequate analgesia is provided. And once so this is the immediate post-operative care, and once patient is uh, recovered from anesthetic effect, we will explain regarding the procedure, all the events, and we will encourage for the breastfeeding and support her in that. So explain regarding the procedure and also her care. And
Yeah. Post-op care, debriefing, clinical governance. Okay, mention all of these things.
okay, so hysterectomy done. After okay, if hysterectomy is done, then incident reporting will be raised. Patient will be debriefed regarding the procedure, and also
Yeah. Debrief her, counsel her on breastfeeding, contraception, and we will post-operatively you will also want to check her hemoglobin level, that how low it is. If it is less than 6, then this is a case, there is a case for blood transfusion. Otherwise she will just take the postnatal vitamins and the iron supplements to build her hemoglobin level up like that.
mm,
That's all you need to mention here like that. And before taking the patient to the OR, you would like to ensure that the neonatologist knows about her, anesthetist knows about her, has been reviewed by someone senior like that. Okay, that
mm,
is
okay.
okay. That is again the section, so no need to go for that one. So what do you see here?
Fetal vagina, this is fetal head and forceps. Mm,
Okay, no, you have told that one, so you don't have to do that. They can show you different instruments, okay, and they can ask you that explain the procedure for me, that how you will apply the forceps. Okay,
mm.
so let's go to this one.
This is
You know, they brought the topic of audit and the people were startled. They brought the topic of teaching and then again they behaved in the same way.
this episiotomy we have done previously.
Oh, we have done? Okay, that's wonderful. Maybe in the ops we did. No problem.
Mm, this is new. Having to sustain like, mm. So how will you assess the extent of perineal trauma? What I have to say in that one? How will you?
Yeah, you know, fourth degree tear is there. But can she have vulval lacerations? Can she have vaginal lacerations?
Yes.
Okay. Can there be urethral injury? All of these things. So you need to assess. That's why I said assessment. Look at all the structures, see that is the anatomy normal, has it been disrupted like that, okay? All of these
Mm,
things. So still you don't know that this is the fourth degree trauma, okay? So you have to assess in the she sustained a perineal tear. This
okay.
that
So
how you will you repair a fourth degree tear? That is the second part of the question. But what will
second.
be your initial assessment?
Okay, so after the delivery, I will assess the patient for perineal tear under a good light source is available and will examine her vagina, vulva vagina, and the urethra, and need to assess the extent of the tear and need to do the rectal examination for the assessment of an extent of the vagina perineal tear. Hmm. How much? Oh, and next, what to say in this question? How to assess? That's enough.
Yes, the extent of the tears, okay? So you will see that how much of the is there a tear, what is the size of the tear, what is the location, is it bleeding or it is not, is it like clean or it is jagged, and then you will put one finger into the vagina and one finger into the rectum. Are they meeting? So it means that this is fourth degree because the rectal mucosa is also breached. That is the.
Hmm. So after assessment, I will categorize the degree of the tear. Either this is the third or fourth degree perineal tear. And how will you repair a 4-degree perineal tear? So 4-degree perineal tear will be repaired into operation theater under anesthesia and needs to be repaired
Would you
by
like
the
to inform somebody
yes
before
consultant.
taking the patient to the okay? Another thing, Fatma. You will say that you will go, you will clean the area, you will take consent from the patient, you will review her notes for how long she was in labor, it was a case of induced labor or just spontaneous labor like that, and then what time she delivered and what time they realized that there is some injury like that, okay, and how is the baby now, has the baby seen by the pediatrician. So with
Hmm.
consent of the patient in the good light, I will sit in front of the patient, wear sterilized gloves, I will clean the area with a warm tapped water, and then what you will do, you will do the inspection, that what is the
Hmm.
anatomy, is there any discoloration, is there any tear, what is there like that, okay. After that, with permission of the patient, you will put two fingers on the foreshe and you will open the area. You will like to see that there is no urethral injury, there is no vulval injury, there is no vaginal hematoma, and no active bleeding sites. Then I will look
Hmm.
at the perineal tear. I will like put one finger into my little finger with consent of the patient with lubricant into the I will put that finger into the rectum and one finger into the vagina. If they meet, it means that fourth degree tear has occurred like that. Okay, I will change my glove, the one you
Hmm.
use for the rectum like that. Okay,
Hmm.
then I will on the inspection you will see loss of puckering around the anus, which is a sign that the sphincter is gone, that there is a complete tear of the sphincter.
Hmm.
If there is any separate tear, I will take note of that and I will like to make the diagram, and then I will explain to the patient that what has happened, that since the baby was very large, so during the delivery she has sustained a tear down below, and it has involved the muscles and things of her bottom and the back passage muscles, okay. So we need to fix that inside the operating theater. She will
Hmm.
not feel any pain, and we will do that. We will examine her under anesthesia to see that what is the extent of problem. Senior
Hmm.
person will be there who will be directly supervising me, or maybe he or she will do the procedure herself, then describe the procedure. So first, so how do we repair the tears? Do we suture the vaginal mucosa first, or we suture the tear first?
Tear first.
Okay.
And regarding the suture, we are
Yeah.
using the fine suture for daily tear. So Picrel 30 will be
Mhm.
used. Mhm. And um, for the anal mucosa, mm, this is Vicryl 30 will be used, and the sphincter is sutured and end-to-end anastomosis. If whole thickness is stirred, then end-to-end anastomosis will be done.
Okay. So after repairing, what will you like to do? Like you will say that you will suture the rectal epithelium with fine suture, right?
Hmm.
Vicryl 30. Okay.
Hmm.
Knot will be on the inner side so that it will not migrate. You will bury the so that it will not irritate the rectal mucosa. You will bury
Hmm.
the knot under the subcutaneous muscle so that
Hmm.
to prevent knot migration. You are going to suture the inner mucosa in a continuous fashion. You will suture the muscle into 2 to 3 layers with Vicryl 1. You can use Vicryl 2 as well. And after that, you will close the vaginal mucosa with Vicryl Rapid. Okay. And after that, you will put your finger into the first your hand into the vagina to remove any gauze pack. I will not use the small gauzes. I will take a large pack. I will pack the vagina to so that I can see the area clearly, and I will hold the apex of the vagina and I will complete that suture that in the running manner like that. Okay.
Hmm.
Then I will see that there is no bleeding area. I will clean the area. Then with permission of the patient is already sleeping. You have consented her before. So you will do the PR. You will remove the glove. I will do PR to exclude any sutures into the rectum. And after that, I will put Indocet suppositories too inside her rectum so that she will not have pain. After that, you will ask the sister that the counts are complete and patient is fine and no effect, and then we will tell the anesthetist to stop the anesthesia. Okay, I will write down double antibiotic for this patient. That vital signs should be monitored. She should be seen for the any hemorrhage, any bleeding. I will give her good analgesia. And what else you will do for her? Give her antibiotics, and I will give her flagyl also. So you can ask the patient as well that she is not allergic to the metronidazole.
Hmm.
Give that one. Keep her inside
Flagyl.
hospital for 2 3 days, debriefing the patient that what happened, and it can occur more so in the primaries, and 7 out of 100 they are going to have the problem like that. So
Hmm.
then I will invite her questions, okay? And the risk management that everyone should have good training in identification of the rectum of the such tears. And if we are in doubt, they all should be trained that they are going to classify it as a higher degree of the perineal tear. Okay,
Hmm.
do the procedure. Documentation is proper. And patient has any questions, I will ask her. I will tell her that sometimes the patients can have fecal incontinence, sometimes they can have urinary incontinence, and sometimes they can have incontinence to air, like they can't hold on to it like that. Okay, so I will tell her about the pelvic floor physiotherapy. Actually, as per the RCPI guideline, when the patient is still inside hospital, you have to tell her about the physiotherapy. The physiotherapist should see her. Okay, and then what will you do? She will come back. She will continue doing that. If she has swelling or pain, she can do this set spas, and we will stop the antibiotic after 5 days. And then we are going to review her after 6 weeks. If she will have any problem, she will come back to us. So
Hmm.
then important also in her counseling that what is the chance of having another repeat false degree tear? You will say the chance is low. It is less than 2%. Okay. Document everything, invite her questions, make diagrams, and then review her at the post-op visit.
Hmm.
That's what you need to do. Okay, so basically, for the to answer the questions on the surgical procedures accurately, you need to revise your consent guidelines. They are the most important for you. Okay, like that.
Consent
So, dear,
guidelines, situation.
consent guidelines. Okay.
Say